Hello, everyone. It's with great pleasure that I will open this PCR Edu organized webinar entitled Intracoronary Imaging and Intracoronary Physiology, Friends or Foes. My name is Niels van Rooyen. I'm an interventional cardiologist from Nijmegen, the Netherlands. And with me are my good friends and colleagues, Professor Javier Escanet from Madrid and Professor Robert-Jan van Geuns, also from the Netherlands. Now, let's first go to the learning objectives of today's webinar. And these are actually three. So the first learning objective is to learn about the added value of imaging and physiology in left main disease, multivessel disease, and in acute coronary syndrome. Second learning objective will be to learn about the use of IFR and FFR pullback and IFR and FFR post-procedure. And finally, we will try to learn you some tips and tricks on how to use IFAS and how to use OCT in these different circumstances. Okay, well, without further ado, I would now like to hand over to Robert-Jan. And Robert-Jan will tell us everything about the use of intracoronary physiology and imaging in the situation of left main disease. Robert-Jan, the floor is yours.
Thank you very much, Niels. I hope the sound is okay. And as you mentioned, we have three topics for today, and you asked me to talk about left main disease. And I will talk about where is the role of physiology and where is the role of imaging, either OCT, as a technology to optimize your procedures. So we will present a case to you, or I will present a case about a 75-year-old male patient presenting with an inferior MI. I can show you the ECG, but I think that you will believe me that he has an inferior MI. We started showing some images of the left coronary artery system, and you can see there is a potential left main disease, mid-LAD disease, and then some distal LAD disease. Now, we have different projections. You can see all of them, but that's for later on. There is sufficient flow in the left system, and we have to focus on the right system for the moment, where we have an occluded right, and the operator in the evening opened up the right coronary artery very nicely and said, okay, now we have to do a decision and a treatment of the left main disease, and we're going to talk about that in the next part of this presentation. So again, the question is, if there is a distal LAD lesion, a mid-LAD lesion, or proximal LAD lesion, mid-circumflex lesion, and then the left main disease, which is a big question mark, because can we assess the physiological and which problems do we have if we are going to address this issue? Is there an interplay between the circumflex lesion, the LAD lesion, for this assessment? So later on, we will shortly talk about IFR. Javier will talk more about IFR later on, but we will talk about sequential lesions and the IFAS capabilities of helping us to make decisions for treatment and during treatment. I want to talk to you about what do we know about physiology with the FFR of the left main. We know there has been FAME studies, but later on, there has been dedicated left main studies. These are already, I would say, done more than 20 years ago, but we have to realize that the first studies were really small, 54 patients, and the largest which has been presented with left main for the FFR is 200 patients. But what you can see in these slides was that they were comparing or the deferral of left main disease by an FFR which is above 0.8. And you can see that in this study from 2009 from Hamelas that the deferral seems to be pretty much safe. Now, these are the two, I would say, major studies, but later on there has been more studies, which has been summarized in 2015 with an overall advantage or difference between survival 95% versus 89% in the surgical group. So it seems to be that potentially the deferral group is doing better than the surgical group. Now, there's been an officially meta-analysis in 2015, which came up with the cardiac death rate tended to be lower when left main deferred based on the FFR, which just crossing over the line of 1.0. But if you look at the revascularizations, you can see that the patients who had deferred had in the later years on still some interventions, but overall the cardiac death was at least as safe, potentially even better, if you had an FFR-based decision to treat a lesion or not. What do we know about IFR? Now, we have the larger studies, which are Sweetheart and Define FFR. These excluded left mains in their analysis, but last year, 2021, there has been a dedicated study for left main, showing that IFR is a similar size as the FFR studies, around 200 patients, showing that deferral based on IFR is as safe as based on the FFR. So what we start doing this measurement based with an FFR technology with IV adenosine, you can see that the lesion was distally positive with an FFR of 0.52. But then will show you that in the proximal LED, there's an FFR of 0.82, and similar a bit for the circumflex, where you can see it is distally 0.67 and more proximally 0.88. So your first impression say, is this significant or not? It's all above 0.8, but we know that if flow is depressed by distal lesion, it might be not the correct optimal measurement. Now, we'll talk a bit about what do we know from this part, and that has been investigated over many years, 2012, showing it in a bench setup with some tubings. You can see where the left main lesion is created by the arrows, where the LED lesion is created by the arrows. So if you want to read it, you have to go back to 2012 to get the data on it. But I think it was really interesting to see the form of the graph. And what you almost can see that is the FFR is distal, FFR epicardial. Up to 0.06, it almost showed no difference. Even 0.04, there is hardly, you can see it, 0.05 difference maybe between the epicardial FFR and the more true FFR. So really at the left side of the graph, there's the big differences, but these are for very low FFR values in the end, which is similar then done in an animal experiment in 2013 by Dr. Young, which is coming up almost the same kind of graph. On this side, on the left side, you can see at the values below 0.4, potentially there's a truly interplay between the two lesions. Then in the end, the last was, of course, a human study, in this case by William Ferron, who showed that, again, the difference between the true FFR and the measurements is pretty low. And if you do that in the same kind of graph, coming up to you. Yes. That again, in the group of below 0.45, there seems to be an interplay. So the simple message would be then, and if you measure an FFR of above 0.85, potentially there is no interplay, there is no influence of the more distal lesion on the proximal lesion. And therefore an 0.85 is a pretty safe cutoff for your left main, even with distal LAD disease. What else do we have? So we give you again these numbers. We go back that we have measured 0.82 and 0.88, considering that potentially that this patient could be treated with just LAD stenting and circumflex stenting. If you're not sure, we can fall back on IVUS. What do we know from IVUS for decisions on the left main disease? And there's the literature a bit more confusing. There's IVUS data on left main, which is from 2004, done in the US, where you could see that if this is related to the FFR, or correlated to FFR, that an MLA of 0.59 would be pretty predictive of having a significant FFR or not. But later on, done by a Korean study, you can see it's different because they come up with a measurement of 4.8 square millimeters as an optimal cutoff value. So it's a bit difficult to say what is our optimal cutoff value, but if you do the IVUS in the left main and you have these kind of close to 0.8 FFR in the left main, and you have an MLA above 6 square millimeters, probably you won't need an intervention. Now, for the IVUS, there has been a dedicated study comparing the deferral based on the IVUS, and you can see that the luminal area of above or less than 7.5 square millimeter also goes, it's the line C, above 7.5, hardly any events up to 6-7 years. So that seems pretty much safe to defer these patients. Next slide. So if you have decided that the treatment of the left main is indicated based on the physiology, then we have to consider about why is left main bifurcation so much differently, and where does imaging technology help us to make better assumptions. So the difference is that there's a change in a different kind of angulation, probably closer to 80-90 degrees. There might be more calcifications in the ostium of the side branch. It's really difficult to assess, and we will talk about that a bit later on. The side branch in this case is not very small, and the left main by itself, it's on the left side of the figure, might be really large, 5 millimeters. LED might be significant tapering, 3 or 4 millimeters in diameter. And so frequently there's also trifurcations. Now, how can we use IVUS? This has been from the ADEPT DES on how does IVUS potentially impact your procedure. So doing IVUS, it is pretty frequently that you're using more larger size balloons or larger stents. On the other hand, there might be more post-dilatation, which is more in the middle, due to under-expansion or to the malposition and the additional stents. Now, I will go in a bit in the details on that, because just to remember you, what are you talking about? Undersizing means that the stent you have chosen is too small, which results in malposition. And I think IVUS of the left main, 5 millimeters or more, is helping you to choose to optimize your stent, or at least do sufficient post-dilatation to get full apposition. Under expansion is pretty clear, I think, for most of us, really, that the plaque is not giving way and the stent is not in the middle, is not as large as on the edges, and you have a remaining stenosis. So the diameter is large. That was done in Ireland by different authors, Simon Walls and his colleague, and realized that the diameters are usually in the middle area between 5 and 6 millimeters is pretty much a frequent area. Now, I think if I go on, then I can skip some of the slides. Then for the time's sake, I will skip the whole story about stent overexpansion, how to achieve this 5 or 6 millimeters with either kissing balloons or POTS. The short message is that POTS is much better to achieve a full wound circle and full apposition up to 6 millimeters for most type of stents. This is what we have learned from different IVUS studies. If you do the IVUS, what should you try to achieve, which is 5 millimeters in the circumflex, 6 millimeters in the LLD, and 8 millimeters in the left main. That should be sufficient expansion as well, resulting in less events. So I think then you don't want to go into IVUS of side branch detection. So I think this is a better moment to change over to the questions, Niels.
Okay, well, thank you very much for this this great interview. And indeed, we have some questions from the audience, and I would like to start with one of the questions that just came in right now, and I think that is also what this is all about. So, how complementary are they? Are they friends or are they foes in the specific setting? And that's a question by Jorge Quizeno. I hope I pronounced this right. And he is asking you, shouldn't imaging be complemented and its diagnostic and management power increased with physiology? In other words, should you use them both in the situation of left main stenting? So look at the anatomy with IVUS and then look at the severity with physiology and combine the two? Or would you prefer to just choose one of the two options?
I'm absolutely for favoring to, if you are in doubt, which means that potentially up to 80% diameter stenosis, you do additional technologies to make a decision if the lesion is physiological important, and preferable FFR as a technology. There's a pressure-based technology, pressure-derived technology, based technology to make the decision if something is physiological important, except if you have real issues about can we measure it correctly or not. But maybe Javier continues. So FFR is the big decision, do we need to treat it or not? And then IVUS really is helpful in to make the results optimal. It has been studied by several people. It is no randomized trials, but there are propensity matched comparisons between with IVUS or without IVUS. And that's why the guidelines give the advice of 2A to do the IVUS to optimize your procedure, to optimize the stent sizing and to optimize the apposition and expansion of both the main branch and the side branch.
Okay, thank you. Javier, what's your opinion on that?
Thank you, Luis. I think I agree with the comment by Robert Jan. I think, as he has demonstrated, all the studies that we have about IVUS to set the indication of PCI in the left main were supported by studies that use physiology as a reference. So the cutoffs that we use for IVUS were derived in the first place from FFR. And from that perspective, I feel that, still, if you have a responsibility for performing physiological assessment first, it is your main choice. As Robert has mentioned, the only issue is when you have doubts as whether distal disease that is not perhaps treatable or whatever is playing a role in the physiology on the left main, or on the contrary, of whether you will have to send the patient for surgery because he has multiple stenosis in the coronary artery. In that regard, I think that, the criteria based with IVUS are very useful as well. Finally, as Robert Jan has said, we have at least one trial that is the defined left main study, which was studying about 300 and something patients who were either treated based on IFR or deferred based on IFR. And like the studies with FFR, they came with the conclusion that patients have similar outcomes. Of course, always slightly worse outcomes in patients who require treatment. But that is obviously due largely to the inherent problems of revascularization in the long term.
Mm-hmm. Okay. And Robert Jan, maybe to you one final question. Sorry, the lights are going down here. One final question to you, Robert Jan. The OCT versus IVUS for left main.
Yeah, absolutely. And there has been 2 studies demonstrating that I would say OCT is very useful. It is the French Le Mans study, and in the ideal left main, we also did do OCT in over 100 patients of the ideal left main trial, and both showed that OCT is very feasible and give you the same parameters as you would like to have from IVUS. The only limitation is potentially the true osteum, but I think it is mostly the problem is achieving good expansion. 80% of the left mains are bifurcation lesions in the distal shaft, and these are especially very good to visualize with OCT as well. On the other hand, you could say that we know in principle that if you want to do the IVUS, you have to do it from both pullbacks from both distal vessels, and also a pre and kind of post to do the sizing, and that comes up to 3/4 5 lesions. So OCT is possible, gives you very good quality, but usually you do it pretty frequently, and then the IVUS has some advantage of using less contrast.
Exactly. Okay, well, thank you very much for these comments and your great overview. I would like then to hand over to Javier Escanet, and he will inform us about the use of physiology and imaging in the setting of multivessel disease. Javier, please go ahead.
Thank you, Niels. And I choose for this presentation of a case that I'm sure will give us room to discuss among us and with the participants all these important aspects of physiology and IVUS in multivessel disease. As you can see here, this was a 70-year-old gentleman who had not only cardiovascular risk factors, but a previous history of coronary artery disease with anterolateral STEMI and primary PCI to the proximal and mid-LAD. There are some stents placed in that angiogram right. We know also that he had some non-viable myocardium in part of the LAD territory, as demonstrated with MRI. But now the patient has not only symptoms in terms of chest pain, but also some degree of heart failure. And the point is knowing if revascularization in this patient will be indicated. Because in the angiogram, we noticed that there was, on top of severe calcification of the left coronary artery, you had this severe stenosis in the mid-LAD, intermediate stenosis in the left main, ambiguous stenosis, and also an ambiguous stenosis in the left circumflex coronary artery. So a patient with multivessel disease and left main involvement. Here you can see a nice image of the angiograms. The right coronary artery have no stenosis. So the patient was discussed based on performance scores with the limitations of scores in patients like this, with loss of myocardium due to previous myocardial infarction. But the consensus is that either PCI or coverage could be indicated, and the final decision was to perform PCI. So I'm going to show you the first key aspect revealing on how physiology may contribute to plan the intervention in this patient. Remember that we have the questions of, well, is this left main stenosis severe or not? It's important to know this when we, of course, start doing the case, to what degree the fact that the patient had previous myocardial infarction is making that these stenosis are not relevant. So we start performing a single measurement of IFR that was very positive. Not only that, you can see that in the pullback, there are two sequential steps that indicate that there is a loss in pressure at 2 levels. Then with this, we co-registered physiology with angiography. Now, remember that each of these yellow bits accounts for a loss of 0.0 units of IFR, and you can see 2 areas where these bits tend to accumulate. The one that we are scrolling now over it. And importantly, when we do this, you can see that we have modified the values of IFR from 0.68 to 0.85. 0.85 will be the IFR that you will obtain if you treat only the mid-LAD stenosis. Now you can see also the left main, you will get a much normal value, 0.95. So what this operation has helped us with is to planify our strategy. We know now that if we really want to get a good functional result in this gentleman, we have to treat not only the mid-LAD stenosis, we have also to treat the stenosis that is located in the main. What about the circumflex coronary artery? There was also a moderate stenosis at that level. So we do the same operation. We go with the pressure before embarking into stenting. It takes just 5 minutes more. We perform a pullback. And first thing we notice is that, yes, there is flow limiting disease in the lateral territory. The question is this due to the stenosis in the left main, or is this due to the stenosis in the circumflex, or to both? After that, what we do is, again, we performed a pressure pullback with the wire. And this actually, I'm going to show you very quickly the result in the next slide. You can see on the right that actually, at the difference with the LAD, the stenosis in the mid-circumflex is not functionally significant. What matters here is the stenosis at the left main, which, as you can see, causes an IFR of 0.84 downstream the left main, but strictly related to the hemodynamic effect of the left main. So I think that, Niels, I hope that this is good for the colleagues in showing how we are moving more and more to planning our intervention, these simulations of what are going to be the expected functional results if you treat this or you treat that. In this particular case, of course, very important because it revealed that the left main stenosis had certainly to be treated. So now we move to IVUS. Why IVUS is important? Well, first of all, remember that we have here serious disease with lots of calcification. In fact, the IVUS catheter is not able to be advanced, as you can see in the proximal AD. You already notice that there is nearly a concentric ring of calcium. So we perform a predilation with a balloon, and then we advance our IVUS, and then we explore the vessel properly. So already from the angiogram, we have lots of calcification, but now we have a much better granularity depiction of what happens there. We see the regions where we have the calcium, the previously implanted stents. We see regions where we have nodules of calcium that perhaps require specific treatment. And with this information, of course, it became clear to us that we had to use a technique for plaque preparation before considering stenting. It will not be enough to use just a plain balloon predilation in this scenario. But luckily, the previously implanted stent is well studied, and there is no significant new intimal proliferation inside. So with this information, we performed at different levels. We treated the mid-LAD and the main. Of course, you can see that we have left a wire in the circumflex at this particular point because we have to treat the bifurcation of the left main to some extent, or at least to preserve that there is no occlusion of the side branch. When we perform this type of treatment, we always sequentially use, different sizes of balloons with a larger one before the bifurcation, so we do not displace the carina. We perform the stent implantations and perform POT, and of course we assess with IVUS what is the result. And the objective here is extremely important. You really have to ensure that you have full expansion of the stent, full apposition. We were lucky in that IBL had already performed an in-depth preparation of the plaque. We performed measurements and we were happy regarding the results of the stents implanted in the middle AD and at the level of the left main, which were, by the way, overlapped with the stents implanted at the time of primary PCI in the LAD. The good thing about co-registering this with angiography is that you can correlate very nicely the images that you're obtaining with IVUS. So if you need to perform subsequent intervention to optimize the segment, you can really locate it very nicely in the angiogram, which at the end of the day is the tool you use to guide your intracoronary tools like balloons, etc. Well, I think that in many occasions in the past we were called this a day, but nowadays we know that it's important always to check with physiology what is the result of your intervention. So we placed a pressure guide wire down the LAD, we performed a pullback, and we had a bit of a surprise because you can see that the IFR is quite abnormal. And when we performed co-registration, we noticed that there was quite significant stenosis, that probably, was overlooked, or that it was in a way part of the effect that we had with this multiple disease. Whenever you have very tight stenosis, even if you're using resting indexes, and you have serial stenosis, my suggestion is always to reanalyze at the end with, reinterrogate at the end with pressure guide wire. So we protected the diagonal, as you can see there. We performed the intervention, and then it was very good. We obtained a very good result. And actually, after that, the functional result was very good. We had to make some corrections for some pressure drift, but demonstrating that actually we have transformed that particular focal pattern of disease that you saw there in this diffuse pattern of disease that, of course, you barely can modify with subsequent actions. So we accepted this as a good functional result, and we were very happy that we had spotted, that there was one and because otherwise it would have contributed to a suboptimal result. This is the final angiographic result. I have already shown you the final functional result. So what did we learn with this case? And probably this is a good example for the discussion with the participants. What it was very useful for us was using correlation of IFR and angiography to plan PCI and to predict the functional result. That was how we, from the very beginning, before touching, the coronary arteries with stents or balloons, we already made the decision of which segments we had to treat. We knew that there was no need to treat the left circumflex coronary artery, and every study in the field of multivessel disease physiology insists on the dramatic reduction in number of stenosis that need treatment based on physiology. As a complement to the lecture by Robert Jan, I think that the case illustrates very nicely how you can separate the assessment of separate the hemodynamic contribution of the left main and distal disease using these tools. And I think that we will be doing this more and more. IBUS was, of course, very useful. I insist that nowadays, I would say that 80% of the cases we perform IBUS with co-registration. It takes 3 minutes more, but it actually gives you so much information and actionable information because you know exactly where to treat, etc. It was very important in this particular case with so much calcium to ensure that we had performed good plaque preparation and good stent. And finally, we shared with you the surprise of having, some residual disease that if you are just trusting your angiogram or imaging, you might leave behind, and obviously will have contributed to a worse functional result. So thank you for your attention. I look forward to your comments, Niels. And Robert Jan.
Thank you very much, Javier. Fantastic case. We do have some trouble with the sound. Sorry to the audience. We will try to fix that. But many cases also here, pictures say much more than words. And I think it was a very clear presentation showing, displaying all the options that we have nowadays in the cath lab. My first question, and I think that's a question that maybe some of the colleagues in the audience will also have, is what is the extra investment with regard to time and also with regard to money if you want to do a procedure like this? So interventional cardiology 2.0 or 3.0 maybe.
Well, when you are considering, procedures where you perform plaque preparation with IVL, multivessel disease, getting good results, I think that we have to really understand that these interventions are not cheap. More importantly, these are interventions that if you really embark into doing them, you have to do the right thing. You have to really get the plus result. I think that this is something that will become a much more stronger in the future. Now, I understand that this way of operating, of working, may not be the one that everyone has access in the cath labs, but it's a matter of time, and this is something that is there. It does not substantially increase the cost of the procedures, and I'm positive that if you really make a proper assessment on the gain that you obtain with in terms of quality of life years, in terms of long-term repercussion, on the life of the patient, I'm positive that this is the way of proceeding. there is nothing here that has substantially increased the costs. A pressure guide wire is a cheap instrument. IBUS is being used everywhere, and getting a correlation with angiography is not something that contributes to expense to great costs.
No, and regarding the extra time that you require.
Well, again, that's something that is very important. Again, if you want to do these cases, you have to do them right. You have to do them well. And the time that you invest is in making good plaque preparation, for example. And the time that you invest in these patients in medications before the patient is in the cath lab, you invest lots of time in deciding what is the best way to approach, in looking to a lot of tests, etc., etc. So exactly when you're in the cath lab, you have to use all the tools you have to perform this. Now, if you tell me, well, I have a problem because I have 20 cases to do in one day and I have one cath lab, then I will tell you that's a completely different discussion. And we need to reconsider if you are in a position to perform this type of interventions. That's an entirely different thing. But I think, as I say, I'm positive that more and more interventional cardiologists will be under the pressure of whenever they perform vascularization, they should do the right thing. They should do a great job.
Yeah, and I think it's also our responsibility to convince policymakers that we should really go for best results in individual patients. And in the end, I mean, that's not only in the for the best will of that patient, but also from a financial perspective, and also from a perspective on how to use efficiently your cath labs. You want to deliver a good result, and nowadays we are able to deliver such good results. Robert Jan, what are your reflections?
No, I think that following the same discussion, I think, you won't do this whole setup for the 20 patients with type A and B1 lesions coming in an ACS situation. This is when you consider the patient Javier was showing is somebody who will spend 3 hours in an operating room having a cabbage versus 2 hours or 90 minutes if you're going fast for the situation Javier is doing. So you have to compare this 3-vessel disease treatment, left main treatment, to cabbage therapy. And you want to be as good as the surgeon. This is the way you have to do these complex patients. Otherwise you lose it. And Javier has been a major lead in Syntax 2 following these results, that you really can achieve results similar to what the surgeons do. But this is the way to do it. It's not for all patients, but this for patients who otherwise would have surgery.
If I may respect what you say, it's like if you are saying, oh, I'm sorry, I did not use arterial grafts in the patients, I used saphenous because we have many patients to do in the cath lab. And it's actually much more time-consuming to perform lima grafts in the patients. So I wish I would like to be doing more lima grafts, but I'm sorry. You will not accept that for sure. So thank you for bringing to putting at the same level what we do to what we do, to what our surgical do in the operating theater.
Yeah. Then maybe one final comment from you, Javier. Maybe you can reflect on the results of the FAME3. Do you think we as interventional cardiologists did already the best job we could, or can we go?
Well, FAME3 is a study that had a hypothesis behind. Is what makes the difference between the results that the surgeons have in the operating theater and us in interventional cardiology is the use of physiology. And I think that is a bridge too far. I feel that there are many other things that we use in the cath lab that contribute to a great success. Well, I'd like to show you today the importance of using intracoronary imaging, for example.
Exactly.
Even the way that physiology is used is entirely different. In FAME3, they did not perform what we did in this case, of checking at the end of the procedure what was the result of the intervention, and then realizing that there was an stenosis that was left behind. And something is even more important compared with Syntax 2. FAME3, by assuming that what makes the difference between outcomes of surgery and physiology, and PCI is the use of physiology, forgot that there are certain patients that definitely, we got lots of information that they are better off with surgery. And it's better to leave these patients out of the discussion. We are not trying to do every patient with triple vessel disease as interventional cardiologists. I think that we should focus on those patients that have an equipoise in risk, that we believe, because we have used the proper indexes, that we know that we have similar expectancy in the long term of outcomes with PCI and coverage. And that is what we try to do at the difference with FAME3 syntax.
Yeah. No, totally agree. Well, I think we can discuss this for hours and hours, but for sake of time, I think we have to move on to the last presentation, which will be presented by myself. Yes, very good. So I also have a presentation built around a case, and this is a bit different from the previous cases. So in this case, we have a male patient, 62 years old, with no cardiac history. And the patient presented to the emergency department because he had chest pain during cycling. He was a very enthusiastic cycler. And that was the day before the presentation. And it disappeared after ceasing his cycling activities. But then at night, the pain returned. And he also mentioned that he had the same complaints at previous occasions, particularly during emotional stress. So physical examination, nothing really abnormal, except maybe from very high blood pressure. And laboratory, the troponin levels were elevated at 190. Also, the EKG, not very gross abnormalities, maybe only a fragmented QRS complex in the inferior leads and also negative T waves there. So let's go to the angiogram. So this is the right coronary artery, and there were some wall abnormalities, but certainly no clear culprit for his non-STEMI. And actually, at the left coronary artery, the same. So also some wall abnormalities, and in the LED, maybe somewhat more. So intermediate lesions, 50-60%, and maybe a little sluggish, slow flow in the LED, but certainly not a clear culprit lesion. So we decided to, and you can also see that in this left cranial view. So in the proximal and mid LED, some stenosis, but certainly not severe, and as said, somewhat slow flow. So we decided to perform intracoronary physiology, and that was normal. So the IFR was above 0.89 at 0.93. And then that leads us to the discussion, can we use intracoronary physiology in the setting of acute coronary syndrome? Well, there is some data on that. For example, there has been a sub-study from the FAME trial, and there they could show that also in acute coronary syndrome, FFR outperforms angiography-based decision-making. And that actually the risk reduction that you can get is higher in acute coronary syndrome than the risk reduction that you can achieve in stable coronary artery disease. And also there has been a study published by Javier, and that was from the Define Flare and the IFR Sweetheart, where they also did a sub-study in ACS patients, and there it was shown that FFR and IFR were equivalent also in the setting of non-STEMI. Now, this is, and there was also actually a question from the audience. Now, what to do in the setting of acute coronary syndrome in these non-culprit lesions? What we do know is that there are, of course, hemodynamic disturbances in that setting. And indeed, hemodynamic measurements are affected by that, especially FFR seems to be affected a little bit more than IFR is affected, and they go in opposite directions. And that can be explained by the fact that during especially a large myocardial infarct, your basal flow will go up a little bit, and that will lead to a decrease in your IFR, and at the same time, your maximal hyperemic response is decreased in the setting of STEMI, and therefore your FFR cannot go to, or you will not reach maximal hyperemia, and your FFR will be a little bit higher, so might be false negative in that setting. Now, this is all about non-culprit. What about the use of physiology in culprit lesions? Let me see if I can go there. Well, there is not much data about that. There is this study, the famous non-STEMI study, and there FFR was implemented in suspected culprits or unknown culprit settings, and there FFR actually did not perform that well. So at the end, as you can see, the graphs came more or less at the same level, and especially during follow-up, MACE was mainly seen in the FFR-guided group as compared to the angiography-guided group. So back to our case, we didn't identify a clear culprit lesion. We didn't see obstructive coronary artery disease, at least not hemodynamically significant. So that's why we coined this as a MINOCA. And the patient was treated with DEPT and referred to the outpatient clinic. Now, a little later, 3 months later, again, he presented himself with an episode of chest pain. This time, no elevated troponin levels, but some EKG changes. And then we decided not, again, to perform an invasive coronary angiogram, but pragmatically treat him with diltiazem under the suspicion of vasospasm. And that went well for a couple of weeks, but then he came back to the outpatient clinic again, and then he said, now, well, I really have regular episodes of chest pain, so I want to have a clear diagnosis. So that's when we decided to plan a coronary function test. And well, I'll quickly go through these backgrounds just for the sake of time. But important to realize is coronary function test nowadays consists of two components. So you're trying to look for two different endotypes of coronary or endothelial dysfunction. The first being coronary artery spasm, which can be provoked by giving acetylcholine. And it is very important that there's actually three pillars if you want to get that diagnosis. So first of all, and that is very important, and sometimes we forget about this, but the patient has to have recognizable complaints during the acetylcholine provocation, because that's what the patients refer to. So the patient has complaints, and then we want to rule out or demonstrate that this is due to vasospasm, but that's why you really have to ask the patient on the table whether they have recognizable complaints. Well, then the second pillar is that you see ischemic changes on the EKG, and the third pillar is the angiogram, so that there's actually more than 90% vasoconstriction. If the first two are present, but there's no 90% vasoconstriction, then we coin this as microvascular spasm. So the second component is more the looking at coronary microvascular dysfunction, so more fixed problems. And for that, we use adenosine, and we assess coronary flow reserve as well as resistance by the index of microvascular resistance, IMR. And the cutoffs for CFR are 2.0 and for IMR are 25 in this setting. And actually, both these tests are guideline recommended with a 2A/B level of recommendation. So let's go back to the case. This is the baseline angiogram. As you can see, the LAD is open, normal flow, no clear epicardial obstructive disease. And this is what we saw after 200 micrograms of acetylcholine, which is actually the highest dose. And now you can clearly recognize the spasm in the distal part of the LAD. But this patient had no complaints during the test and during this dosage of acetylcholine. So thereby this has to be coined as a negative test for spasm. Then the CFR and the IMR measurements, as you can see, both were normal. So CFR was 4.3 and IMR was well below the threshold of 25 at 16. Then we also performed FFR, and this was a little bit to our surprise because, as said, at the index event, we had a normal IFR, but now we had an FFR, which was actually positive at 0.78. As you can also see, though, the pressure gradient, the drop is very gradual. So there's not a clear jump in the pressure. It's very diffuse. And that's also what we saw on the angiogram. So, taken together, we concluded that the coronary function testing was negative, both for spasm as well as for a fixed microvascular dysfunction. But there was obstructive epicardial disease, which was, however, too diffuse for stenting. So, again, we recommended conservative treatment. Now, the story doesn't end yet there. So another couple of months later, 19 months after the initial presentation, again, he came to the emergency department. Again, after cycling, he had chest pain, which did not subside this time. Again, no clear abnormalities at the EKG, but this time, again, raised troponin at 265. So he was referred to the cath lab again, and what we saw was pretty much the same as at the previous angiograms. So an LAD with intermediate lesions, maybe again a little bit slow flow in the LAD. And what the plan was to do an FFR and more or less confirm the positive FFR of the previous angiogram, and then do stenting of the proximal LAD and the mid LAD, hopefully thereby solving his problem. But much to our surprise, now again we had a normal FFR, or at least not a FFR below 0.80. So the FFR now measured was 0.83. So then we were a little bit puzzled, and then finally we decided also to use intracoronary imaging. Now let's go to this, and maybe I'll skip this one and go to this. So what we saw was a lot of atherosclerotic disease, both calcified as well as more soft plaques, but most importantly in the proximal LAD, and we're almost there. So here you see quite normal vessel wall still. That's a side branch. And now watch closely because it goes rather quick. There you see irregularities at 9 to 12 o'clock. And let's go to the next one. I have some still frames here. So this is what we found in the proximal LAD. So there was thrombus over some 10 millimeter trajectory, no clear plaque, ruptured plaque surrounded by it. So most probably what we're looking at here is erosion. And then again, we were, of course, a little bit in doubt because there has been a very nice Japanese study where they followed up patients with erosion and then conservative treatment for a year. And the vast majority of those patients fare well just on medical treatment. Nevertheless, because this was the third presentation of this case, and we decided in this case to treat that lesion. So that's what we did. We placed the stent only at the trajectory where we saw the erosion, and then we did again OCT, and I'll just show you for sake of the still frames. So we had a nice result, no distal dissection, nicely opposed stent struts. As you can see in the middle panel, protrusion of the thrombus. And then proximally there was malapposition, mainly because there the vessel was too large for the stent or otherwise. So we did a post dilation there with a nice result. So I think this is a very illustrative case, and this patient really got caught up into a cycle of diagnosis where we went from non-STEMI to MINOCA to microvascular dysfunction, then to stable angina, and then after almost 2 years back to non-STEMI again. And I think this really illustrates that if you're in the cath lab and you have a patient and you don't really understand what you're looking at, use the tools that you have available and use upfront both physiology, but also intracoronary imaging. And I think that could have saved us time, but especially that could have saved the patient a lot of time, and we could much more upfront have reassured them, give him the right diagnosis. So, and that's what we're also trying to implement in our lab. Try to also in the setting of STEMI non-culprit lesions, but also in the setting of non-STEMI, where you're not very certain about what your culprit lesion is, use these tools. So use physiology, but also use intracoronary imaging, and trying to get to the right diagnosis and, of course, then the subsequent right treatment. That's pretty much what I have to present. So, Robert-Jan, Javier, I'm very interested in what your reflections are on this case.
Well, if I may start first, I think it's a very interesting case. And the first comment to make to you and to the colleagues, particularly to the participants, is that having availability of these rich techniques for physiology and imaging will help you in having more information, but sometimes the decision still may be difficult and the diagnostic may be difficult. The only thing that think the other way around, think if they will be trying to work out what happens, just having a look to the angiogram that is performed again and again and again. And it was thanks to this that you actually outlined the concurrence of many different problems in this particular patient. Eventually, you came to demonstrate something that it is very important. There was erosion. Most likely, the mobilization of material from this erosion explains why this time the FFR was higher than before. So there's a rational explanation for everything. But from my point of view, the take-home message is do not expect that in every single case, the information from physiology and imaging is going to produce an answer to the very complex scenario of coronary cases. You need to think about it, but you will make, I believe, more solid decisions.
Yes, thanks. Niels, so excellent case, and I'm looking at the timings, and we have 1.5 minutes to go. I think Javier is talking as well. But, what I wanted to say is that I think we're coming back to why you decided on this title for this webinar, saying friends or foes, and I would say that we are absolutely friends, all of us. But I think the message of today is the friends between physiology and imaging. They are really complementary. Maybe not in all cases you have to do all, but today we have seen several cases where they have been friends and the patients have benefited for using both technologies. And I think your case was also an excellent representation. So I would almost take over your role as chairman and say, because you're the last presenter, so thank you very much for your contribution and saying an excellent work. But you're the chairman, so you find us up with saying that we are friends, and friends with physiology and imaging, and they are both needed in several cases.
No, well, I think, well, thank you for taking over the role of chairman. I could have done better in this respect, and I totally agree. We're sitting here as friends, as presenters, and I think we nicely demonstrated that also in the cath lab, in the setting of both complex multivessel disease, left main, ACS. These techniques are really complementary, and there's many instances where we should implement them, use them, and as said, don't think about too much about the extra time or the extra euros. We are here for the patients, giving them the best treatment possible, and if we want to do that, we have to implement these two friends, imaging and physiology. I would like to thank the organizers. I would like to thank the audience, and of course, hopefully see as many as possible of you live during PCR in Paris. Thank you very much. Bye-bye.